what the cardiologist needs to know about COVID-19 and the cardiovascular disease. So in a couple of minutes, I'm going to cover very important points: COVID-19 biology, diagnosis of COVID-19, cardiovascular comorbidities in patients with COVID-19, the mechanisms of cardiac involvement in patients with COVID-19, the cardiovascular risks from COVID-19 regarding myocardial injury, myocarditis, acute coronary syndrome. What is the difference between COVID-19 and heart failure? Is it COVID-19 or heart failure or both? And how to handle the medications of cardiovascular drugs in the setting of positive patients with COVID-19. So we know that COVID-19 is caused by a pathogen known as SARS-CoV-2, which is a novel enveloped RNA beta coronavirus that is thought to originate in bats. The infection mainly occurs when this virus caused by binding of the spike protein on the surface of the virus to the angiotensin converting enzyme 2, which is known as ACE2 receptor. According to this mechanism, the virus will be internalized and propagated within the cell with the viral replication. So the key factor in the pathogenesis of COVID-19 is angiotensin converting enzyme 2 receptor, which is found mainly in pneumocytes in the lungs, as well as in heart, arteries, kidneys, and intestine. And when activated ACE2, normally it converts angiotensin 2 to angiotensin 1 to 7, which has a vasodilator effect. So this is a beneficial effect. But when SARS-CoV-2 binds to this receptor, ACE2, this will lead to downregulation of the ACE2. And accordingly, angiotensin 2 will increase. And angiotensin 2 has a deleterious effect because it induces acute lung injury, adverse myocardial remodeling, vasoconstriction, and increased vascular. Dr. Ayman, do you hear me?
انا سامعك بس السلايدز مش طالعه على الشاشه. حضرتك محتاج تعمل شير سكرين. يعني صوت حضرتك واضح جدا بس ما فيش سلايدز طالعه يا فندم. فشير سكرين من فضلك. كده السلايدز متشافه يا فندم. That's okay. شكرا يا فندم.
So the spike protein of SARS-CoV-2 will bind to angiotensin converting enzyme ACE2, and this will lead to entry of the virus, internalization, endocytosis, replication, and consequently downregulation of ACE2. And with downregulation of ACE2, so there is no more conversion of angiotensin 2 to angiotensin 1 to 7, which has a vasodilator effect. So angiotensin 2 will increase, which has a deleterious effect because it induces acute lung injury, adverse myocardial remodeling, vasoconstriction, and increased vascular permeability, and this will lead to ARDS. The spectrum of COVID-19, as we know, that 81% of cases are mild cases with no pneumonia or mild pneumonia. However, 14% of patients are presenting with shortness of breath with a respiratory rate of more than 30 per minute, with desaturation, oxygen saturation less than 93%, with lung infiltrates more than 50% within 1 to 2 days. However, 5% of patients have a critical situation in the form of shock, needs for mechanical ventilation, and at the end, the multi-organ failure, which is responsible for increased mortality. The clinical features of COVID-19, as we know, have a different presentations: fever, cough, myalgia or fatigue, sputum production, diarrhea, leukopenia, lymphopenia, high liver enzymes, high creatinine, increased LDH, increased troponin I in 12% of patients, and the procalcitonin may be normal or decreased, and around 30% of patients develop acute respiratory distress syndrome. Acute cardiac injury have been reported in 12%, acute kidney injury in 7%, septic shock 7%, and secondary infection in 10%. And the diagnostic criteria of COVID-19, suspected cases, as we know, travel to areas in which COVID-19 is present all over the world, contact with patients who have COVID-19, contact with patients with fever or respiratory symptoms suggestive of COVID-19 or cluster cases. Clinical symptoms, fever, respiratory symptoms, imaging characteristic of COVID-19, normal or decreased leukocytic count, and lymphopenia. So any one criteria of epidemiological history plus any two clinical symptoms indicate suspected cases, and all three clinical symptoms also indicate suspected cases. While confirmed cases, it means suspected cases plus etiological or serological evidence of COVID-19 in the form of SARS-CoV-2 RNA positive by PCR serology specific for SARS-CoV-2, IgG-M and IgG are positive in the serum. So let us to start with cardiac injury in patients with COVID-19, because COVID-19 is not only a disease of the respiratory system. The mortality in most of the cases are cardiac in etiology. Why this happens? Because COVID-19 could, through the ACE2 mediated direct damage, will lead to increased affinity to angiotensin converting enzyme A2 with consequent increase in angiotensin 2 levels, or reduced expression of the ACE2 because the virus mainly works through ACE2, and dysregulation of the renin-angiotensin system. Hypoxia induced myocardial injury, one of the mechanisms, because this will lead to increased oxidative stress, intracellular acidosis, and mitochondrial damage. Cardiac microvascular damage also have been speculated to play an important role and increase the vessel permeability, angiosperm, microthrombosis also are involved in the pathogenesis. And finally, systemic inflammatory response syndrome characterized by cytokine storm, in which a release of more of the elements responsible for cytokine storm, such as interleukin-6, such as troponin, and increased inflammatory markers, which will lead to this systemic inflammatory response syndrome, as well as dysregulated immunocytes and uncontrolled inflammations. All these mechanisms will lead to acute cardiac injury in patients who have COVID-19. So the cardiac manifestations of COVID-19 may be one of the following: acute myocardial injury, and this is detected by high level of high sensitive troponin I, ECG changes, and left ventricular systolic or diastolic dysfunction. Myocarditis, Takotsubo cardiomyopathy, and at the end, multi-organ failure. Myocardial infarction could be type 2 myocardial infarction due to supply-demand imbalance, or microvascular dysfunction, or a myocardial infarction with normal coronary arteries known as minocarditis. Pericarditis, maybe effusion and tamponade in some cases. Pulmonary embolism also have been reported, which should be suspected when the patients develop sudden deterioration in addition to hypotension. Heart failure could be de novo heart failure, acute decompensated heart failure in patients who have previous heart failure, HFrEF or HFF also have been reported. Cardiogenic shock, different arrhythmias, atrial fibrillation, ventricular arrhythmias, and finally sudden death. Even in patients who have been recovered, some cases have sudden cardiac death, which may be one of the causes, long QT syndrome, for example, due to the medications. This is an example from an autopsy, patients who have myocarditis. And if we look here, we can see the mononuclear cell infiltrations of the myocardium indicating myocarditis. It's diffuse in the lungs, in the liver, as well as in the myocardium, in addition to microthrombosis. And this is one of the papers which have been published in JAMA recently for more than 1,000 patients suspected to have COVID-19. At the end, they did an analysis for 416 patients who have confirmed COVID-19. 82 patients have cardiac injury detected by high level of cardiac troponin, and more than 300 patients have no cardiac injury. If we look for the outcome, the survival rate was high in patients who have no cardiac involvement. So 51% mortality was cardiac involvement, compared with 5% in patients who have no evidence of cardiac involvement. And this is a multivariate Cox regression analysis on the risk factors associated with mortality. And again, we can see that in the presence of cardiac injury, the hazard ratio for mortality from the symptom onset or from admission is significant, with a p-value significant compared with other variables included in the analysis. So cardiac injury is an important predictor of mortality in patients with COVID-19. And another study involved more than 130 patients looking for cardiac involvement. And we can see that arrhythmias have been involved in 16%, acute cardiac injury 7%, and troponin was high. So if you look for patients who needs ICU admission compared with patients who have not admitted to the ICU, we can see that acute cardiac injury and arrhythmias have been associated with the need for admission to the intensive care unit. And this is a very interesting review article for the potential effects of coronavirus on the cardiovascular system. And again, the coronavirus can affect the myocardium, lead to myocarditis, and severe myocarditis can develop with reduced systolic function, with increased biomarkers, and the myocardial injury is likely associated with infection-related myocarditis and or ischemia, and it is considered as an important prognostic marker. Again, patients who have underlying cardiovascular disease, hypertension, coronary artery disease, cardiomyopathy, viral illness in such patients can lead to more viral direct damage by the virus, increased systemic inflammatory response, destabilization of coronary plaques, and aggravated hypoxia. So these data suggest that myocardial biomarkers should be evaluated in patients with cardiovascular disease who develop COVID-19 for risk stratification as well as for early and aggressive intervention. This is very important. And the conclusion of this interesting paper that myocardial injury is significantly associated with fatal outcome of COVID-19. Although the prognosis of patients with underlying cardiovascular disease but without myocardial injury is relatively favorable, however, myocardial injury is associated with cardiac dysfunction and arrhythmias, and the inflammation may be a potential mechanism. Aggressive treatment may be considered for patients at high risk of myocardial injury. This is an example for young patients who have COVID-19 positive, chest pain, dyspnea, X-ray, cardiomegaly, chest CT suggestive of COVID-19. ECG have an evidence of ST elevation inferior leads, high levels of cardiac troponin, ejection fraction 27%. So fulminant myocarditis in this situation, which was treated aggressively, included the immunoglobulin as well as steroids. And 1 week later, we can see that the chest X-ray normalized and the ejection fraction returned to normal. So fulminant myocarditis in such situation is very important because it can lead to mortality. Abnormal coagulation is common in severe COVID-19, and D-dimer levels can be increased. So significantly increased D-dimer, as we can see, is associated with poor prognosis as well as fibrin degradation products. Vascular endothelial inflammation with extensive intravascular microthrombosis by autopsy have been detected. So this raises the question, do we need anticoagulation in those patients? So anticoagulation therapy should be considered and initiated for severe COVID-19 patients if it is not contraindicated, because pulmonary embolism is common in such situation. And this is an interesting slide, showed that the factors associated with increased incidence of ARDS as well as increased mortality, age above 65 years, comorbid conditions like hypertension, diabetes, fever, lymphopenia, elevated end organ indices like liver enzymes, PUN, elevated inflammatory markers, CRP and ferritin, and increased coagulation markers like D-dimer and prothrombin time. And this is a post-mortem for one of the patients who died due to COVID-19, and we can see the significant hemorrhagic necrosis in the lungs due to this disease. So patients with COVID-19 can develop acute coronary syndrome, yes, because COVID-19 can trigger many of the pathways which increase the susceptibility to acute coronary syndrome. Endothelial activation, oxidation of LDL, increased platelet activation, expression of tissue factor. So we can see acute coronary syndrome in such situations. And the myocardial infarction may be type 1 due to ruptured plaque, or type 2 due to oxygen supply demand imbalance in such situations due to hypoxia. And this is an example for patients who have STEMI, ST elevation inferior leads, and increased troponin ejection fraction decreased to 45%, and he was treated for acute coronary syndrome and COVID-19. So what are the recommendations for management of patients who have acute myocardial infarction during COVID-19 outbreak? Now we have many recommendations. If we look for the EC, and this also was confirmed by the ACC, how to manage patients presenting with acute myocardial infarction. Emergency intravenous thrombolysis is the first choice for acute STEMI. For STEMI patients with confirmed COVID-19, strict isolation should be started, and you have to rule out contraindications for thrombolytic therapy. So if COVID-19 could be excluded by the expert group within less than 1 hour, the possibility of having COVID-19 is small. So in such situations, we can monitor closely and conduct a PCI with coronary intervention immediately after eliminating COVID-19. Or to proceed with the thrombolytic therapy, the decision should be done according to the benefit to risk ratio. For non-STEMI, the greatest risk stratification is important to identify high-risk patients who are considered a candidate for intervention. However, medical treatment should be given, and the risk stratification should be conducted while awaiting the results of ruling out COVID-19. So for non-STEMI patients excluded from COVID-19, early or time-limited intervention should be selected immediately according to the risk stratification. If you have a high-grade risk score and COVID-19 excluded, so interventions can be done. Otherwise, medical treatment is the main strategy of treatment for those patients. And this slide shows the pathway for management of STEMI after ruling out COVID-19. And the high-risk patients with cardiogenic shock, hemodynamic instability, ongoing refractory chest pain, or patients who receive thrombolysis and still have chest pain, so rescue PCI is recommended. And again, non-STEMI patients, great risk score stratification, high-risk patients should be admitted to the CCU, and PCI should be done after rule out COVID-19. Otherwise, conservative strategy is the main approach for patients with non-STEMI, especially if he has a low-grade risk score. The SKY recommendations regarding management of STEMI patients, also they recommended that fibrinolytic therapy may be considered in low-risk STEMI patients, patients who have inferior STEMI without right ventricular involvement or lateral myocardial infarction without hemodynamic compromise. And in the high-risk patients like cardiogenic shock patients, PCI should be done. However, in the cath lab, maximal protection is important to prevent staph exposure. This should be including effective personal protective equipment. PPE is very important in this situation in the cath lab to protect the operator as well as all staff in the cath lab. Now, patients with heart failure presenting with more shortness of breath, cough, if this is decompensated heart failure or this is COVID-19, and how to differentiate. So this is a very important statement by the Canadian Cardiovascular Society, features that would increase the probability of COVID-19 versus heart failure exacerbation. If the patients have increased individual risk of contracting COVID-19, degree of according to the degree of isolation, social distancing, amount of community spread of COVID-19, the risk factors for developing COVID-19. You have to review all this by the history. However, the presence of fever and or de novo viral symptoms like cough, myalgia, and fatigue, fever is present in 50 to 80% of patients, so this increases the possibility of COVID-19. The absence of typical features of heart failure, like weight gain, ankle edema, the pattern of shortness of breath is different. Patients with acute decompensated heart failure usually have dyspnea associated with paroxysmal nocturnal dyspnea. So in such situation, it is it's different from the usual presentation of acute decompensated heart failure. And very importantly, the lack of response to diuretics. This in favor of COVID-19. Don't depend on natriuretic peptides and troponin because both are increased in COVID-19 and they cannot differentiate. So follow-up communication is important to assess for symptoms, resolution, or progression at 24 hours to 48 hours according to the clinical situations to differentiate between COVID-19 and heart failure. So this diagram shows that is it heart failure or is it a COVID-19 according to the history, according to the de novo viral symptoms and or fever. So this indicates that COVID-19 is more likely. However, if the patient is presenting mainly with dyspnea, cough, fatigue, so heart failure or COVID-19 could be a possibility, but in the presence of more edema, ascites, weight gain only, this favors the diagnosis of heart failure after excluding COVID-19. So going to the strategy of management for severe patients with COVID-19 and develop heart dysfunction, you have to treat based on symptoms, prevent complications, treat pre-existing disease, organ functional support in time. So respiratory support for critically ill patients, acute heart failure, ECMO should be available. Circulatory support, fluid resuscitation, improve the microcirculation, continuous renal replacement therapy to protect the kidney as early as possible, survivor plasma therapy for critically ill patients with rapid progress, blood purification treatment for cytokine storm, and in patients who develop cytokine storm, the use of interleukin-6 blocker like tocilizumab have been very effective in treating patients with severe illness with cytokine storm. A very important entity in treating patients with COVID-19, whether to continue ACE inhibitor or ARBs or to stop these medications. Why this question is important? Because at the beginning of COVID-19 treatment, there was a concern about the use of ACE inhibitor and ARBs and whether the continuation of ACE or ARBs is deleterious or not, because the virus mainly acts through ACE2 and the use of more ACE2 lead to more down regulation of ACE2 with increased angiotensin 2. So this concern was abandoned and abolished by the new recommendations. If we look for the ACC-AHA recommendation, we can see that the recommendation is to continue RAS blockers, whether ACE or ARBs, and individualized treatment decision should be done according to the hemodynamic status and according to the clinical presentation. EC Council on Hypertension, European Society of Hypertension, all these statements are strongly recommend the continuation of ACE inhibitor, ARBs, in patients who have hypertension, heart failure, ischemic heart disease during COVID-19. And we don't have any evidence to stop these beneficial medications when you are treating patients who have cardiovascular disease on ACE inhibitor or ARBs. And these recommendations also from the Canadian Society of Hypertension, the Canadian Cardiovascular Society and Canadian Heart Failure Society, International Society of Hypertension, the British Cardiac Society. And the take-home message regarding this important point that ACE2 protein facilitates entry of coronavirus into the cells. ACE inhibitors do not impact ACE2 because ACE and ACE2 are different enzymes, and there is no any evidence supported that the hypothesis that ACE inhibitor or ARBs increase expression and increase coronavirus entry. So the current evidence does not support the discontinuation of ACE inhibitor treatment due to coronavirus infection. So you have to continue ACE and ARBs in those patients. And this is an interesting slide that shows how to handle the medications, cardiovascular medications during treatment of COVID-19. What about antiplatelets, statins, antiarrhythmic drugs? If we look for aspirin, it is safe. P2Y12 inhibitor, especially after PCI, is important. Anticoagulation, NOACs or VKA, you have to be very cautiously, and you can replace by intravenous heparin. Statins are safe to be maintained in primary and secondary prevention, but you have to look for liver enzymes. If the liver enzymes are very high, so statins should be stopped, and you can give a drug like ezetimibe. Beta blockers, in the presence of severe hypoxia, severe airway spasm, in such situations, you have to stop beta blockers, and you can give ivabradine to control heart rate. However, in the absence of severe hypoxia or severe bronchospasm, beta blockers can be given in the form of beta-1 selective beta blockers like metoprolol or bisoprolol. The drugs which increase QT interval, you have to be very cautiously with flecainide, amiodarone, sutalol, because chloroquine, hydroxychloroquine drugs, which are used in treatment of coronavirus, increase the QT interval. So you have to be very cautiously when combining other drugs which prolong QT interval. It's the same with diuretics, which induce hypokalemia and they can increase the long QT. And colchicine is safe. Non-steroidal anti-inflammatory, you have to be very cautious and to be stopped if possible. And digoxin also to be stopped if possible. And you have to measure the QT, and the digoxin level also is important. Drug-drug interaction is important when you are treating patients, because inhibitors of cytochrome P3A, which is an isomer of cytochrome P45. So antiviral drugs like lopinavir and ritonavir may increase liver injury and cause elevation of muscle enzymes, especially if taken with the statins like atorvastatin and simvastatin. Also, you have to be very alert to the direct or indirect damaging effect of antiviral drugs on the heart. So chloroquine again increase the probability of sudden death due to torsade de bois and long QT interval. Antiviral drugs may lower the heart rate by unknown mechanism. So this is also a very interesting risk score for drug-associated corrected QT prolongation. If you have an age above 68, you will get 1 point. Female gender, the use of loop diuretics, hypokalemia, baseline corrected QT more than 450 millisecond, acute MI, more than 2 drugs, prolonged QT interval, sepsis, heart failure. You have to use this risk score if you have a low score less than 6 points. So the risk for QT prolongation is very low. A moderate risk if you have 7 to 10 points, while if you have total points of more than 11 points, this indicates a high risk patients to develop long QT syndrome with the risk of torsade de bois and serious ventricular arrhythmias and increased mortality. Again, this is also an algorithm before starting the hydroxychloroquine, which prolongs the QT interval. You have to rule out congenital long QT syndrome, acquired long QT syndrome, drugs which prolong QT interval like azithromycin, structural heart disease, bradycardia. And then you have to calculate the corrected QT, especially after the first dose. And you have to be very cautiously if the patients develop the more prolongation of the corrected QT above 500 milliseconds or increased ventricular ectomy, because this increases the risk more. So at the end, management of strategy of COVID-19 combined with cardiovascular disease, early self-management is very important, and you have to avoid acute cardiac events, heart failure and acute coronary syndrome. Diagnosis of COVID-19 early is very important with the ECG and blood pressure monitoring and the early intervention. Respiratory support for patients who have evidence of hypoxia, circulatory support, immunotherapy in severe cases with cytokine storm by the use of tocilizumab, very important. and you have to rule out drug-drug interaction, especially drugs which induce pro-arrhythmic effect, vasoactive agents inducing acute coronary events due to vasospasm, drug interaction which induce liver injury. At the end, I'd like to thank you for your attention, and please stay home, stay safe. Stay safe. Thank you very much.